In this section, we're going to look at what happens mechanically during one heartbeat. The terms that we use for the contraction phase of the heart is systole, and for the relaxation phase of the heart is diastole. So it'll contract, systole, and diastole. We have to think of some of the volumes that are happening. Think of when the heart is in diastole. So it's relaxed and it's filling because it's relaxing, right? It's not ejecting. So when it's in systole, it's ejecting. When it's in diastole, it's filling. So let's think of that time when it's filling, and it fills and fills and fills. That total volume that was able to fill that ventricle is called EDV, or end diastolic volume. So it's the volume at the end of diastole, at the end of the relaxation, or at the end of filling. Defined here, total blood volume of blood in the ventricles at the end of diastole, and it's around 135 milliliters, around, more or less. Okay. So let's move on here. The end diastolic volume in a diagram is showing it's come in from the atria, it's filled in both ventricles, and it's as full as it's going to be. That's the volume at the end of diastole, or end diastolic volume. See if you can picture it that way, it's helpful. Okay, what about ESV, end systolic volume? So think of the volume at the end of systole. So now you've squeezed, contracted, or ejected. You squeeze that heart, blood shoots out of it, and what you have left behind, because it does not eject every drop in there. No, it doesn't. That volume of blood left behind in the ventricles at the end of systole is end systolic volume. You only eject about 60 to 70%. So some of that is going to still be left behind in the ventricle. Okay, another important, we talked about value is that we talked about stroke volume before, remember? So stroke volume is the blood ejected from the ventricles during systole. So think of what it is now in terms of end diastolic volume and end systolic volume. It's just a different way of thinking about it. If you take the end diastolic volume, in other words, the total filling, and take away the total amount that was left behind after ejection, then you're going to have the volume that you actually eject, right? Which is stroke volume. We're interested in stroke volume, remember, because this is what you're going to use to irrigate your tissues. So that's the value we want. So end of systole, it's totally full. End of diastole, excuse me, totally full. End of systole, some of it left behind. If we take away that left behind from the total full, we have that stroke volume value, and it's around 70 mLs as a mean. Okay, approximately. So that's how much you're ejecting every time you go into systole. This is a really nice way of thinking of it as a plastic bottle. So you're filling this plastic bottle, right, in diastole. The end diastolic volume is that volume that's in there. And then systole is when you eject. And the end systolic volume is what's left behind post-ejection. Good? I think this is really helpful for me visually seeing it. There's another term that comes up here, which is afterload. So afterload has to do with, I'm going to give you another slide here, is the resistance that the ventricle of the heart has to overcome to be able to eject that blood from the ventricle chamber. So if I'm thinking of it in this diagram, this is closed. I have to be able to overcome this force here of a closed valve, of this narrow vessel here. And so I'm going back one slide. The afterload then is the force that you must overcome in order for that blood to eject. Okay, that's afterload. Okay, some stroke volume values. Think of this. When you're resting, and let's say you're a non-athlete and your stroke volume is around 75, that sounds good, and your heart rate is around 75. A marathoner, right, would have a huge stroke volume. And why is that? Because they're very efficient. They have this heart that is a muscle, which is so efficient. Every time it contracts, it ejects way more blood than the regular couch potato. Okay? So therefore, this value being so big, the heart rate doesn't need to be as frequent. It can be much less so. It can only beat 50 times and still move just as much fluid, just as much blood. Okay, so these are normal values that you would see in a trained aerobic athlete and a non-trained athlete. Let's talk about blood pressure. There's 3 very important variables that are going to determine blood pressure. One of them, again, is cardiac output. Okay, how much is ejecting every time you're in systole. Blood volume. So is your blood volume greater than the 5 liters? Therefore, that system's under greater pressure, or is it less, or is it a norm? And the third one that's going to affect blood pressure is the peripheral resistance. Do you have atherosclerosis? Are those vessels so narrowed from cholesterol that there's increased peripheral resistance, increasing blood pressure? The flow of blood is dependent on that pressure gradient. And we talked about this before because when we talked about flow and Poiseuille's equation, remember? So during systole, contraction increases the pressure in the heart chamber. That makes sense, right? You're squeezing this muscle and you have fluid in there, so it's going to increase the pressure in that chamber. So blood is going to naturally flow into the next chamber or vessel where there's lower pressure. You're just sort of squeezing this water balloon and it's going to squeeze water, in this case blood, out into a region that's lower pressure. In diastole, relaxation decreases the pressure until the blood flow stops. So if we wanted to graph this in terms of volume here, volume changes during systole and during diastole. Let's see if this makes sense to you. You would have a certain volume of fluid, which is blood, a certain volume of blood, and it's going to fill that chamber, fill that ventricle. And then it's going to stop filling, and it's going to be a certain volume for a little bit until it starts to squeeze, right? And it contracts, nothing happens, contracts, nothing happens, until it's going to overcome the pressure of those valves, of the semilunar valves. So that pressure gets so big, then finally it starts ejecting. And if it's ejecting, does it make sense that that volume is going to drop? Because it's going out into the aorta or into the pulmonary trunk. So it's going to stop, it's going to go lower, until it sort of evens out. There's no change. Until it's diastole. In diastole, you start to fill it back up again. So you're filling back up again. And I'm going to leave this here to talk about at a later time. So for now, we're just thinking of equal volume when the pressure has not yet overcome the valves, drop in volume once it starts to leave the heart, and then increase in volume once it starts to fill up again. And because this has to do with the valves, you would be able to hear the first sound and the second sound, which are lub-dub, lub-dub. So you would hear the lub right at the time where it's actually has a closed atrioventricular valve. It can't go back into the atria, and you're hearing the noise until finally the blood is ejecting, and then it crashes back on the semilunar valve. So this region here would be AV valves. This region here would be semilunar valves. So this has to just do with volume. We're thinking of volume changes. Fill and eject, and fill and eject. And so in this case, in this eject and fill, and it's going to always be eject and fill. Okay. So let's look at it in pictures. In late diastole, both sets of chambers are relaxed and the ventricles are going to fill. So this is, both are relaxed, and this blood is going to come in here and it's going to move on to here. Same thing over here, it's coming in here and it's going to move on to here. Atrial systole. So systole here is contraction. So atrial systole is, this is quite full and these contract. When they contract, they're going to force the blood down into the ventricles. Not just by the weight of the blood, but now the active contraction. So any extra blood that's in there that didn't already drop will move due to that contraction. 3 now. So now it's filled in here. Think of this. This is full with blood. And now I want to squeeze, I eject. Can't go back in here because this is blocked. You cannot go back here. And it's going to try and exit through here. But this is still closed. So there's a time there where the pressure increases, nothing happens. The pressure increases, nothing happens. And then finally it's going to eject. So there's that period of time where nothing happens, is called iso, which is same, volumic, same volume of contraction, meaning the contraction is happening, but nothing is yet ejecting. So let me read this to you. Isovolumic ventricular contraction. The first phase of ventricular contraction pushes the AV valves closed. Here we go, we closed it. But does not create enough pressure to open the semilunar. Therefore, there's a short period of time there where even though the contraction is starting, ejection hasn't yet happened. Now that pressure has been high enough so that ejection is occurring. So we're calling it ventricular ejection. As ventricular pressure rises and exceeds the pressure in the arteries here downstream, these semilunar valves open and blood is ejected. Now we're going to have another isovolumic, same volumic volume, ventricular relaxation. As the ventricles relax, so this is relaxing in the ventricles, pressure in the ventricles falls, blood flows back into the cups of the semilunar valves. So it goes back into the semilunar valves and snaps them closed. So there is none yet coming in. There is none of it coming back. So it's iso same volume of ventricle volume of blood in the ventricles. So it's going to be an isovolumic ventricular relaxation. And there's that slide again. I'm going to skip it now. There is a diagram called the Wiggers diagram done by Mr. Wiggers that's quite complex, but I showed you a piece of that. So I showed you the volume, right? Volume would rise and drop and rise and drop, and that's what would be happening during atrial systole, during ventricular systole, ventricular diastole, and atrial systole. This diagram I always advise students to stare at for hours. Why so? Because it has so much information on it that will help you understand the big picture. Up here is the ECG that you looked at. Okay, P, QRS, T, P, QRS. But you want to know this is happening electrically, and you also want to know, it's not a very good E, what is happening with volume, which is here, and what's happening with pressure, and what's happening with the heart sounds. So in pressure, I just want to look at the red line only. You have the left ventricular pressure. The pressure in the ventricle is low during atrial systole. Nothing's happening until it fills, right? And then that pressure is going to increase. It's filled. It's going to increase, increase, increase until you open those valves. From the ventricle, you open the semilunar valves, and then blood's going to eject, and that pressure is going to drop back down again. So a really nice diagram. This is confusing at first, but I urge you to spend some time looking at this because it has nice information. It tells you what's happening mechanically. It shows you pictures here of where the blood is going, and it gives you a really nice summary of what's happening during systole and diastole in the heart. Remember cardiac output, heart rate times stroke volume in milliliters per minute. The average heart rate at rest, 60 to 70 beats per minute. During exercise, about 145. The average stroke volume at rest, about 70. During exercise, way more, about 200. So the average cardiac output at rest, remember, is about almost 5 liters. And during exercise, it would be 29. So this is 4.9 or 5, and this is 29 liters, or 29,000 milliliters. So you're moving a lot of blood during these ejections, depending on whether you're at rest or during exercise. When could potentially your cardiac output be altered? So as a general rule, I'm telling you here, a patient with a heart rate that's too fast, perhaps it's so fast that there's not enough time for filling, and then you wouldn't be able to have enough cardiac output. Or if it were very, very slow, then it would have enough time to fill, but you need to be distributing oxygen and you're kind of behind on that distribution of oxygen, which is quite dangerous. That's why it's saying needing urgent assessment here. So this is all about cardiac output being too high or too low. Sometimes the heart rate is not quite average. So we were talking earlier about how the resting heart rate of an athlete could be quite low. And the resting heart rate of an individual with anxiety could be really high. And then in kids, it's much higher than that of adults. I noticed that some of you had kids doing the VO2 max for you, and those heart rates were a lot higher. So look at this. At birth, pretty high. 6 months, 130 beats per minute. A year, it starts to drop. If you had your 10-year-old doing your VO2 max, it was about 95. So this is just sort of, I'll never ask you these tiny details. Just know that in children, it's going to be higher. That heart rate's going to be higher. This is a graph showing that the stroke volume then in kids and the stroke volume in an adult. Their heart rate is higher, so their stroke volume is lower. Okay, hope that's clear, the relationship between those two. How about regulation of heart rate? They had an experiment. Physiologists performed an experiment. to see which of the two, the sympathetic or the parasympathetic, was more in control of the heart rate, like during homeostasis. And what they found was, they severed the parasympathetic neurons, and then they severed the sympathetic in a different organism to see what would happen to that heart rate. And what they found that when the parasympathetic input was blocked or removed or cut, the heart rate would shoot up to about 90 beats per minute. So they concluded that it was actually the parasympathetic that is in greater control of that resting heart rate, because it's trying to hold it down at a certain heart rate, and were you to remove that, that heart rate would shoot up. Another question that comes up is, does conduction velocity change other than in the SA node? Remember SA node? The AV node is also affected. So acetylcholine is a neurotransmitter, and that neurotransmitter from the parasympathetic neurons slows the conduction of the action potential. And epinephrine and norepinephrine, or adrenaline and noradrenaline from the sympathetic, increase the conduction of that action potential. And that is both of the AV node and of the SA node. Both of those are under the control of these neurotransmitters. The regulation of the stroke volume is affected by two things: the contractility of the heart, how good it is at being able to contract, and also, this is a tricky one to think of, also the length of the muscle fibers at the beginning of the contraction. What's that mean? It means stretch. How stretched is that muscle at the time of the filling? And think of it in terms of overlap of actin and myosin. If it's very overlapped already, then that contraction is going to be limited. If it's not very overlapped, then that contraction can be more forceful, correct? It depends on how much of that overlap already exists. So look at this. When we think of contractility, you have sympathetic innervation and epinephrine are going to increase the contractility, right? So the sympathetic nervous system is going to make you contract harder. So you have a scare, and all of a sudden your heart starts to beat really fast. That's because the sympathetic has kicked in, and it's going to increase both the velocity and the contractility. So it's going to contract more forcefully. And the other way around, the parasympathetic is going to decrease that. This is trying to show how stretch optimizes the length-tension relationship. It's a lot of words, but I think you'll understand this. If here you look at force, and on this axis you're looking at stretch, then you have a certain amount of stretch coming from the volume of blood left in that ventricle at the end of diastole. So you're filling it. Think of this water balloon that's filling with a lot of water or a lot of blood in the heart. It's going to fill, 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 fill. And if you fill it with 135 milliliters, then the amount of force that can be created here is at about 70. But let's say you filled it way more. Let's say you filled that water balloon so much more, and you're coming up here. Now you come across, and this is going to be much higher, the force, because you fill the water balloon with a greater volume inside it. So that's all it's telling you, that the increased stretch is going to optimize that force. So if you're thinking by now, well, who cares about this? It makes sense, because if all of a sudden we have more blood coming into the heart, it is essential that that heart contracts more forcefully, because if not, it's not going to be able to eject that blood. So it's sort of a reaction to it. The more stretch, the stronger the contraction. The greater the stretch, the stronger the contraction. Some people, or students, usually think, wow, stretching is not a good thing, right? You don't want this heart to be overstretched. And no, it's okay. It means that you have a larger end diastolic volume. You could have just started running on the track, and you have more blood returning to the heart. And so it's filled it with more blood, and you need to eject more forcefully if you're going to move that blood. So it's fine. Why do you need to move more blood? Well, because the oxygen demand has increased. You went out on the track, and if you're out on the track, you need more oxygen, and therefore you're going to pump a larger volume more forcefully. That is known as the Frank-Starling law of the heart. He figured it out, I guess, thinking that the stroke volume must match the venous return, meaning when you have more blood coming in, you must increase the stroke volume. Greater stretch, greater force, greater ejection. Defined for you as venous return is the amount of blood that fills that right atrium and will come down into the right ventricle. And will fill them, both ventricles. So venous return is the amount of blood that is coming into that atrium that will then eventually be ejected, and the same goes for the left side of the heart. So, in conclusion, increased venous return increases end diastolic volume, right? And if you have more diastolic volume, you must contract more forcefully. How do you increase venous return? I sort of mentioned that already. How is it that all of a sudden you get more blood coming into the atria? Well, there's a skeletal muscle pump. So you started running and you're moving those muscles and you're moving that venous blood more forcefully. You have a respiratory pump. All of a sudden you're breathing more deeply and you're forcing that low pressure in the thorax. When breathing decreases the pressure in the inferior vena cava and it draws more blood in from the abdomen. So you're bringing in more abdominal blood. And the sympathetic innervation of the veins. So there's going to be constriction and more squeezing of the heart. So those three are going to cause an increase in that venous return. When that system fails, remember the afterload, the tension or stress developed in the wall of the left ventricle? So the combined pressure of the end diastolic volume and the arterial resistance. Let's assume again someone has atherosclerosis and you have the pressure of all that blood at the end of diastole and you have atherosclerosis and you have this ventricular contraction. What if that afterload pressure is too big? What if it's just hard for the heart to contract with that much force to be able to eject it? Let's say the aorta also is less compliant. Why would it be less compliant? Well, because it too has hardening of the arteries and it's become stiff, so it's not helping pump at all. So then the heart is going to have to pump harder and use more ATP. This is when these cells are going to become enlarged. There's going to be hypertrophy of those cells. You're going to have an enlarged heart. So this enlarged heart is not the enlarged heart of the healthy athlete. This is the enlarged heart of someone with atherosclerosis that is just working their heart 24 hours a day trying to overcome that arterial resistance caused by arterial disease. That was just a slide, a reminder of afterload, right? It's the resistance of the ventricle that the ventricle of the heart has to overcome in order to be able to eject that blood. How do you test for afterload? The arterial blood pressure is an indicator of afterload. And that ejection fraction, how much you're ejecting, can be measured by ultrasound. So they can see how much is filling and then what percentage of that blood you are ejecting during one contraction. So that's done with ultrasound to see whether you do have a heart disease. And that was the last slide. These are some videos that I'm going to post in the video section of Canvas about aortic stenosis, when afterload is affected because the valves are not working well. Okay, this was a long one, half an hour. Thanks, everyone. That's the end of this chapter.